in the management of aphakia and other zonulopathies. So without wasting time, because I think 4 minutes has gone out of our time, I think Dr. Aghahon, please, you can start.
Okay, thank you very much. Good morning, senior colleagues and colleagues. This morning I'll be talking about iris claw lens implantation in the management of aphakia and other zonulopathies. And I'll be doing that under the following outline. Okay, so cataract remains one of the leading causes of reversible vision loss in Nigeria. And then the low surgical rate is one of the major reasons why cataract still remains a leading cause of reversible vision loss. Of course, the surgical uptake in our environment is poor, and then we, the ophthalmologists, are not evenly distributed across the country. So some cataract surgical cases are done without lens implantation due to various reasons, maybe due to complications, or maybe patients with zonulopathies and then want to have a secondary implantation. So at that point, patients are left aphakic. Okay, so we just know that aphakia is the absence of the crystalline lens, and it is a common finding in developing countries like ours. Then zonulopathy is a state in which there is deficiency of zonular support for the lenticular capsule. So it could be a subluxation or a dislocation where the lens is completely dislocated to another part of the eye, maybe in the vitreous or even the posterior segments. Okay, so, and zonulopathies can be a congenital finding or could be acquired. Like the pictures we have below, if you look at the one on the left, so it's showing us some cases of congenital zonulopathy. And then the picture on the right is just a patient that is aphakic. Okay. So the intraocular lens implantation is a method of choice for correcting aphakia and other zonulopathies. So the implantation, like I said earlier, could be done as a primary procedure where a patient that has zonulopathy, maybe a congenital anomaly like Marfan's or the rest, you can just, do a cataract surgery and then implant the intraocular lens, or it could be a secondary procedure. So the choice of intraocular lens is based on the surgeon's choice and also the surgical skills, and there are various patient factors that we'll consider when we want to pick the choice of intraocular lens for managing aphakia. So this picture here on this slide is showing us the various options for intraocular lens implantation in this category of patients. The first one to the right of to the left of our screen is showing us the anterior chamber intraocular lens, what it looks like. Then the one in the middle is scleral fixated intraocular lens, while the one to the right of the screen is the iris claw intraocular lens, which is what we're talking about. Okay, so iris claw lens is used for adult cases and has been documented in pediatric aphakia or pediatric patients with lens subluxation when contact lens may not be tolerated by the patient, and then we need to have a good visual optimization. Okay, so we'll look at the etiology. The etiology of zonulopathic insufficiency could be maybe surgically induced, like when we are doing cataract surgery and there's a complication, so we leave the patient aphakic, or it could be traumatic aphakia. Then it could be from lens dislocation in systemic involvement, like I said, like a Marfan syndrome or Weber-Marchesani syndrome, sulfite oxidase deficiency, and some other metabolic conditions, even congenital or secondary weakness of the zonals. It could be from ectopia lenses or from couching. Couching is common in our environment. Some patients are left aphakic from couching. Then it could just be trauma generally causing weakness of the zonals. Okay, so it could be these other causes are not directly they're not direct cause of zonular insufficiency, but indirectly they could lead to zonular insufficiency. Patients with chronic, poorly controlled glaucoma over time could lead to the ocular structure instability and changes, which will eventually cause zonal weakness. Likewise, fuchs could lead to increase intraocular pressure, and then corneal guttata, as we know, it's a pathology of the endothelium of the cornea. So inadvertently, it will lead to increase in intraocular pressure, cause distortion of the ocular structure, and then eventually lead to zonal weakness. Likewise, a patient that has low cornea endothelial cell count. Okay, so what are the indications for surgery? Patients with good potential for visual acuity. We want to do a secondary intraocular lens implantation or a primary for a patient we think will not have good potential for visual acuity. So in other words, it's good to select our patients. We have to investigate them, especially check the posterior segments and also send them for ocular B-scan to be sure that there is good potential for good visual acuity. So patients that cannot tolerate contact lens, like in our environment due to hygiene and all that, so surgery can be offered to such patients. Then patients that are unable to or unwilling to use aphakic spectacles. We know all the problems associated with aphakic spectacles, image distortion and all that. So because of that, you want to offer patient surgery. And then patients that are unable to get refractive surgeries. Okay, so the contraindications could be patients with uncontrolled glaucoma, patients that have active, chronic, or recurrent uveitis, patients with iris atrophy or patients that have had distortion in their iris structure, because you need a good iris structure to be able to implant your iris claw lens. Okay, so a patient with iris atrophy or distortion of the iris definitely cannot benefit from iris claw implantation. Then patients with severe anterior segment structural abnormalities and patients that have endothelial cell counts of less than 2,000 cells definitely cannot benefit. And then we have to check the anterior chamber depth to be sure that, using a slit lamp examination, to be sure that the anterior chamber depth is less than 3 millimeters for patients that will have prepupillary iris claw lens. But for those that will do retropupillary, which is what we often use, the anterior chamber depth can be 3 millimeters. Because of course we know that we have to constrict, unlike our other cataract surgeries for iris claw, we have to keep the pupil constricted. Okay, so patients that will benefit from this surgery, you want to examine them. First of all, doing a detailed history. We want to know the age of the patient, and then find out if there is history of trauma, if patient had surgery in the past, or if the patient has other anomaly, both systemic and ocular anomaly that could cause zonal insufficiency. Then we want to check the best corrected visual acuity, check for pediatric patients if there is amblyopia, or even for older patients. Then we want to check if patient has strabismus. We want to do a retinoscopy and refract patients. Then, like I said, a slit lamp examination is very important because we want to check the cornea diameter to know if patient has megalocornea. We want to be sure that the diameter of the cornea is within normal range. And then, like I mentioned about the iris earlier, I want to check the state of the iris to be sure that patient doesn't have iris atrophy or distortion in the iris. And then you check the pupil as well. We want to check the lens position. If there is any lens, that's for patients that have lens, like those systemic and congenital anomaly. We want to check for Marfan syndrome. Of course, we know that the lens will be dislocated superior temporally. So we want to check all that, check the visual axis, and then check the lens edge. Okay, so it's good for us to measure the intraocular pressure so that we'll know what the baseline intraocular pressure is and be sure that it's not our surgical intervention that increased intraocular pressure, if at all. Then a detailed fundus examination is important, especially checking the periphery to be sure that there's no retinal tear or any pathology at the posterior segment, because if there's a retinal tear, for instance, it's going to cause distortion of the vitreous and cause imbalance, and then the claw will eventually fail later on, causing cystoid macular edema, and even a retinal detachment. Okay, so we'll look at the iris claw lens itself. The iris fixated lenses were first described in 1954. In the early 1960s, Koller implanted the first iris fixated lens after an intracapsular cataract extraction. But in 1971, Watts came in with the iris claw lens. It was fixated in the mid-stroma, where the iris is less vascularized. And over time, that's what we've been using. It has evolved into what we currently are using. That's the artisan lens, like you can see on the screen. So the iris claw lens implantation involves the implantation of the intraocular lens, which is secured with a claw-like haptic that hinges or enclave on the iris. So I'll just use my cursor to point to us. So this is what the artisan iris claw lens looks like. So we can see the optic and the haptic, which is like a claw. So the diameter is like 5.5 millimeters, and then the length from claw to claw is about 9 millimeters. So this is important in when we're trying to make our incision, whether the cornea incision or the scleral tunneling. Okay, so it is relatively common method for implantation of the intraocular lens in the absence of capsular or zonular support. It can be placed either anteriorly or posteriorly to the iris. That is, if it's anterior, it is a pre-pupillary implantation. Then if you place it posterior to the iris, it is a retropupillary implantation. So of course, when we're trying to, before part of the preparation of our patients, it's important we check the biometry, because the A constant for prepupillary is different from that for retropupillary, as you can see on the screen. So we'll look at the procedure itself. So after counseling and taking consent and all that, so we take our patient to theater. So the same way we block 4 or 6, you can do a peribulbar block or you can do a subtenons. Anyone is fine. Then we now do a clear cornea side ports, like we can see on the screen at 3 o'clock and 9 o'clock position. Okay, so the anterior chamber entry is achieved with either a clear cornea incision or a scleral tunnel of about 6 millimeters based on surgeon's preference. Okay, but preferably it's good to do the tunneling because it is self-sealing and it will help us prevent endothelial cell loss. Okay, so anterior chamber is cleared of vitreous and vitreous bands, especially for those that are secondary implantation, because we expect that most times the complication could be due to a posterior chamber rent, causing definitely when we are going in again, vitreous will be in the anterior chamber. So we'll do an anterior vitrectomy. Okay, so the iris claw lens is implanted into the anterior chamber to rest on the iris horizontally, as seen in the picture on the slide. So first of all, remember our diameter is 5.5 millimeters and our incision for the scleral tunneling is 6 millimeters. So we go in vertically first, and then after going in, we now adjust it to lie horizontally so that it can aid our enclavement. Okay, so the anterior chamber is formed using viscoelastic and then side instrumentation inserted via the side ports and the intraocular lens held in place using the iris claw lens introducer. Okay, so like the picture was saying, the first part we use is the left part. So we're trying to enclave the left, and then this other picture is enclaving the right. So we'll feel a click and know that it's really enclaved. So that's why we need, we have to be, it's a bimanual thing. You have to be able to use both hands. Okay, so the anterior chamber is cleared of residual vitreous and viscoelastic. Then the sclera and cornea wound suture is done using 10-0 nylon. So we give our subconj, steroid, and antibiotics. So the next slide I'm going to show us is okay, this is a patient first day post-op. So this is what the pupil look like. You know, most times they have oval pupil, but eventually as time goes on, use of their medication, the pupil becomes round. Okay, so I have a short video, which is about 9-minute video, just to take us through what I've just explained. So in this video, it's actually a primary lens. I want us to see it apart from managing patients as a secondary implantation. It can also be a primary procedure, like in this video I'm about playing a patient with fecolytic glaucoma, where the 6 was performed, and then eventually the patient had the iris claw implantation done. Okay.
This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. This is an elderly male patient who has facolytic glaucoma. He visited quite late. His symptoms were almost about 20 days of pain and redness, and he didn't come to the clinic. Now this is the situation. We have controlled the intraocular pressure, inflammation with medications, and he's doing this surgery. My plan is to do a manual small incision cataract surgery. So I begin my surgery by injecting this very small amount of lignocaine in subconjunctival 26 number needle. Then I'm doing a peritomy, followed by using blunt cannula to inject about 1.5 ml of lignocaine into the posterior subtenon space. I'm expecting the surgery to be slightly long because this case looks to be having a severe zonular dehiscence, and in the inferior quadrant I can see these fluffy lens matter, which appears to be at the level or above the equator of the lens. Not sure about it. So I begin my tunneling and notice how I stabilize the globe. I make a small groove in the sclera itself, much posterior to the incision, which is actually planned. And this is where I hold or stabilize the globe using the tooth forceps. I wouldn't want to hold any part of the conjunctiva there. Planning to make a 6.5 millimeter sclerocorneal tunnel. 1.5 millimeter behind the limbus, it's slightly frowned. Using a crescent blade, a tunnel is being created. Idea of this tunnel, or the shape of the tunnel, is such that it is the central part will be 1.5 millimeter on either side of the limbus, and progressively as we go to the periphery, you can see the distance between the scleral incision and the limbus increases, as does the internal lip as well. So we have a biconcave looking sclerocorneal tunnel. Side ports are done, the anticapsule is stained, viscoelastic is used to deepen the antechamber. When I'm entering into the antechamber, the blade is tilted so that the inner lip always runs parallel to the limbus, so that the inner edge never touches the limbus. It's always running parallel to the limbus. So this ensures long-term stability of the tunnel incision. And I'm using a bend 26 number needle to puncture the anticapsule. And the moment I puncture the anticapsule, it becomes very evident that the bag is extremely loose. It may not be possible for me to save the bag. My planning is to just get a rhexis and try to insert a ring in. Looks to be very unlikely. So I complete the rhexis somehow using a forceps. Using 2 Sinskey hooks, I'm mobilizing the nucleus out of the bag, and then the nucleus is delivered out using a phaco sandwich technique. At this moment, I realize that the bag is extremely loose and it is impossible to salvage the capsular bag. So I'm just using the capsular forceps to peel the bag out and convert it into an intracapsular extraction. This area with the cortex or some lens matter seems to be mixed with the vitreous itself. So without much hesitation, I go in with my vitrector. So I plan to do a bimanual anti-vitrectomy. Takes care of the suspected prolapsed vitreous as well as the lens matter. And in just a couple of minutes, we can clear both the vitreous and the lens matter very efficiently. So now I'm in cortex mode. I wanted to remove all the exudative membrane which is there on the surface of the iris. Then with the same cutter, I change my settings I minimize the cut rate to the minimum and then use aspiration and cut more into a peripheral areolectin under the sclerocorneal tunnel. So once it's done, now is the time to place the lens. So I planned an iris claw lens, and we have the correct diopter lens ready. At this moment, I'm also introducing some pyrocarbon into the eye to constrict the size of the pupil a little bit. I'm not sure whether I'll be successful because long-standing inflammation would have damaged the sphincter muscle. Luckily for me, the pupil does come down. I'm making another fresh side port here. The first side port has quite a long corneal tunnel. So I'm making a fresh limbal parasynthesis incision with a very short intercorneal tunnel. So this would help me to get the enclavation much better. That was the idea. On the other.
Okay, so just to explain something, that's while he was doing his scleral incision, he made it 6 millimeter because he was doing 6. So if it was just a secondary implantation, he made it 6.5. So it was a secondary implantation, the incision would be 6 millimeter. And then when he was doing the vitrectomy, he went as high as 4,000 because he had so much vitreous. Unlike a secondary implantation, what we do is about 400, we do 600 cuts per minute. Okay, so, and he's making another side port, which is the ideal side port for iris claw implantation, because the one he did initially was because he wanted to get a good access for capsulorhexis. So that is why, but for a secondary implantation, the side ports he's doing now is fine. So we still do it at the 3 o'clock and 9 o'clock position.
And the other side port, I was quite happy. So I go in with my iris claw lens. I'm holding this with the iris claw lens forceps. Just want to take a moment here to explain how I'm holding the lens with my forceps. The position of the edge of the forceps directly corresponds to the level of the notch. So that is the idea. By doing this, I get an indirect clue where the claw in the haptic is. The enclavation instrument which I'm going to use is a 26 number hydrodissection cannula. So it goes to the side port and the lens is just lifted up a little bit now. So once it's lifted up, you go in and tap on the iris, it just gets enclaved. Just one attempt itself, I have a good enclavation. I pull the lens away just to check that the iris has got properly enclaved. Time to repeat it other side. Before that, I just come out, inject a little bit of viscoelastic. Again, note the position of the edge of my forceps. This is directly in line with the expected claw in the haptic. So it's easier for me to know where the claw is. This is one small trick which I would like to share here. So because I know where exactly to press now. It goes in here and I know where the claw is going to be. I just want to press it just beside it. That's it. It just gets engaged. And just confirm by pulling it once. Now I go behind the lens with retractor to remove some of the OVD which has gone in. That's it. Unfortunately, some amount of blood has entered into the antechamber and some would trickle down into the vitreous as well and take some time for it to clear. This is how the surgery looks at the end, and not putting any suture, the scleral tunnel incision. The conjunctiva is closed with a white krill suture. This is the picture. The cornea is edematous. There is some amount of secondary glaucoma is there, also inflammation. The pressure was 34. Over a period of time, steroids and anti-glaucoma medication subsides. The patient is doing pretty well with good visual recovery. And at the end of 6 weeks, the pressure is normal without any medications. And built-in OCT of macula as well. And there's no cystoid macular edema. Iris claw.
Okay, so basically this is the procedure. So for us, we also suture the scleral tunnel as well as the conjunctiva using nylon 10-0 suture. Okay. Okay, so we'll look at the advantages of using iris claw intraocular lens. It has a short learning curve, like we've seen. So over time, once we keep doing it, we become perfect at it. Then the anesthesia we use is usually short acting compared to scleral fixated. So though even we use xylocaine and bupivacaine, but surgery time is short, so patients don't stay long on anesthesia. And then it's less expensive. In our environment, I think it goes for 10,000 as compared to scleral fixated, which is 12,000 aside transportation. Okay, so the duration of surgery is shorter. Okay, so the only disadvantage, though not a disadvantage, is that it has by manual dexterity. You have to learn how to use both hands. Okay. So there are some complications that can be encountered with this procedure. So the lens could tilt, or there could be decentration, there could be hypotony, secondary glaucoma, which can be taken care of also. There could be endothelial cell loss, especially if one goes through the corneal incision. Then it could be pigment dispersion. Patient could have ephema, like we saw in the video. Then pupil distortion is common. Okay, so patient could have iris atrophy. There could be vitreous hemorrhage, and then even suprachoroidal hemorrhage could occur just like every other intraocular surgery. Patient could have choroid effusion, cystoid macular edema, retinal detachment, and endophthalmitis. So in conclusion, iris clear lens implantation is relatively easier for managing aphakia and other zonulopathies in the presence of sufficient iris tissue. So compared to other surgical options, the duration of surgery is shorter and it has a shorter learning curve. These are my references. Thank you very much.
Thank you. Dr. Idris, are you there? Hello? Hello, can anyone hear me?
Yes, I can hear you.
Oh, thank you very much, Dr. Aghahon, for this beautiful presentation.
Thank you, ma'am.
Thank you so much. So we can pause now for contributions, questions, comments. Please, you can unmute yourself. Does anybody have any? Kindly indicate first, then you can unmute yourself. I can't see anything in the chat.
Okay, sorry. Good morning. Sorry, I was trying to, I don't think there's an option to raise your hand.
Okay.
Yeah.
Please go ahead.
Okay, thank you for the beautiful presentation. Please, and can she tell us the management of lens tilt, as in, because I noticed that you don't suture the lens. You don't suture the iris claw lens. So if it tilts, or how do you handle that? Thank you.
Sorry. Can we know you better? I didn't see any name.
Oh, sorry. I'm Dr. Chome Melumadu. Although it's Chidera that is showing there, but I'm Dr. Chome Melumadu.
All right, thank you.
Yeah, from Guinness Eye Center, Onisha. Sorry for that.
Oh, thank you. Please go ahead and answer the question.
Okay, thank you very much, ma, for the question. Okay, so if there is iris tilt, it depends on how serious it is. If it's not tilting and affecting the visual axis, if it's okay within that, if the lens is still within the visual axis, we still allow it, we leave it. But if it is affecting the visual axis, then we go in again and try the procedure again.
All right, thank you.
Yes,
Good
ma'am.
morning. I have a question, please. All right, please go ahead.
Thank you, Doc. Well done for the nice presentation. I just want to find out, is it that regardless what you do, iris claw lenses induce raised intraocular pressure, such as that's what we had in the video, the 34 millimeters of mercury that gradually subsided, or that patient already had a predisposition to high pressures?
Okay. It could be a complication. Like I mentioned, one of the complications that patient can have glaucoma. And that's why I said when you're preparing your patients, it's good to check the intraocular pressure. So it serves as a baseline. And then your fundus examination tells you that, okay, before surgery, this patient is not a glaucoma patient. So after surgery, patient's pressure is high, then you treat. So it will be due to the procedure done. Yeah. And after giving them their medication, just like we do in 6, over time, pressure becomes fine and they are off medications.
Okay.
Yeah.
Thank you. There's another question here. Are these foldable iris claw lenses? Somebody's asking. Dr.
Okay,
Francis.
they are not foldable. Just the way you saw it on the slide, that's how it is not foldable.
Okay, then another question is, when you say try the procedure again, do you de-enclave and
Yes.
still re-enclave again?
Yes, you still enclave, because that's why you said when you are selecting your patients, you are sure that the iris is healthy. So you can enclave again because it's the iris tissue is healthy and there's no problem. So you just do anterior vitrectomy again and then enclave.
All right. Thank you. When we enclave, when we look under the slit lamp, can we see the claw lens? Can we see through the stroma of the iris?
No, we can't see. We can't see it.
Okay.
Yes.
Okay. So it's that sound that makes us know, and the fact that the
yes,
other hand can feel the lens that makes us
exactly.
know, yes,
That
it's
it's
there.
enclaved, yes.
Okay. Do you have any more questions, please? Okay, so someone asked, do you recommend primary iris claw implantation in the absence of, sorry about that. Okay,
Hello.
So in the
Hello.
absence of an automated vitrectomy, please hold on, please hold on. So someone is asking, do you recommend primary iris claw implantation in the absence of an automated vitrectomy, like the open sky that we do? Do you advise that?
Okay. Well, the ideal thing should be done really, but in a space where you don't have the ideal. So why not? You can do that.
Okay, okay. So someone also asked that there are 2 side ports. 2 side ports can be used to clear the cortical matter and also for the claw lens insertion instead of 3, as shown in the video. Okay, this one is a contribution from
Okay.
Dr. Ibrahim. Yes. Now we can simply use 2 side ports and not 3. But that video you showed, they did the small incision cataract surgery first.
Yes.
And then they had an additional, yes.
Yes, and that was the reason why it was 3 side ports.
Okay. We have someone wants to ask a question.
Okay, ma'am.
Please, can you unmute yourself? Somebody wanted to ask a question initially.
Okay, thank you very much, ma'am, for your presentation. My name is Diamond Onyobini, Port Harcourt. So mine is a question stroke a contribution.
Okay.
With this transient rise in intraocular pressure that is seen after the procedure, is there no place for a PI to be done? Because I know some people do a PI and post-op, the pressure is not really high. So
Okay.
what do you think about that?
Well, from our experience in my center, we don't do a PI. So once the pressure is high, just like it happened or it can happen in 6, the moment we give them their acetazolamide and then some topical medication, a week post-op pressure is fine. So we're just fine with that rather than causing a PI. That's what we practice anyway in my center.
Okay. Dr. Diamond. Hello. Dr. Diamond, are you still there? I thought she has a contribution and a question. Okay. So someone contributed that sometimes the claw may go through, and then it can also serve as a PI.
Okay. Okay. Thank you, ma'am.
Okay, somebody asked, can we get the presentation slides? Okay, that's not a problem. Then someone said that the video showed a PI was done. I'm not sure about that.
Yes, actually, API was done, but that video was from India, so it's not in our setting. So like I said, we don't do API. And most patients who've had 1 week post-op pressure is fine. So.
Okay, all right. Then I wanted to ask, now that you've done quite a number, and you said the learning curve is short, shorter than scleral fixated IOL. So if you want to, like in a center that's about to start any of the two procedures, where you have residents also doing surgeries, would you advise them to start with iris claw before scleral fixated IOL? I mean, teaching the residents now.
Very well, because teaching the residents, it's easier, and it's easier also to learn, unlike scleral fixated where you have to suture onto the sclera, so it's more complicated. Even the post-op complications are more. So in a teaching facility where residents want to be taught, I still recommend the iris claw. It's just wonderful.
Okay. Okay. So how these iris claw lenses, are they readily available?
Very well. Very well. Readily, just the way we buy the PMMA, very readily available. Just a little bit more expensive than the PMMA, but cheaper than scleral fixated.
Okay. Okay. So more expensive, like 15%, 20%?
Okay, no.
Over the price.
Let's say like 2%.
2%, wow.
Yeah, so it's not so, yeah.
Okay. Okay. Okay, so our senior colleagues in the house, do you want to share your experience with us concerning use of iris claw lenses? Do we have people that would like to share their own experience with us? Please, we'll be glad to have those shared with us. Nobody. Okay, apart from Lasuth, is there any other center where this is being done? Kindly indicate, apart from Lasuth. Nobody's talking. Dr. Ibrahim, in National Eye Center, do you do iris claw?
Good morning. Good morning. Thank you very much for giving me this opportunity. I'm Dr. Ibrahim from National Eye Center. Yeah, the few years I've been here, I don't think I've watched it done. We commonly do sclera fixated. And I think for just like you rightly said, the sclera fixated actually comes with a lot of complications when compared to the iris claw. And I want to believe, and I agree with the presenter as well, the iris claw, it's very, very easier to learn, because watching the video and comparing it with what we actually do in our center, I think our advice for a starter, you should learn the iris claws first. Thank you very much.